for October. All right, welcome everybody. Thank you for joining us for the October edition of the JVS Online Journal Club. Very excited this month to have both the University of Alabama and also the University of Vermont sponsor the JVS Online Journal Club, and two great papers that we're going to be talking about tonight. So one of them is a patient-centered textbook outcomes for contemporary elective abdominal aortic aneurysm repair quality. And sometimes there's such a mouthful. And the other one is high ankle brachial index participants experienced similar long-term mortality as peripheral artery disease in a national sample of community dwelling adults. From the University of Alabama, our faculty host is Dr. Benjamin Pierce, and the integrated second year resident, Dr. Angela Sickles, who's going to be presenting. And then from the University of Vermont, we're very excited to have Dr. Ferris, who is an assistant professor of surgery and associate program director. And then the second year fellow from Vermont, Dr. Sean Leibscher. We have two of our author guests, which is always an exciting thing so that we can direct questions directly to them. So Dr. Amy Felstead from the VA in Boston, and then Dr. Parmar, who is an instructor of medicine at the Harvard School of Medicine. And he's also the director of the Vascular Medicine Fellowship. Finally, also from the West Coast, we have Dawn Burrill, who's going to be joining us as our moderator today, asking the hard questions and really pushing everybody to think a little bit more. The next JVS Online Journal Club is going to be Wednesday, November 13th, and that would be hosted by Thomas Jefferson University and the University of Tennessee. All the dates for the 2024 are posted at vascular.org, and then coming out next week will be the sign-up sheet for both site hosting and moderators for 2025. Just keep in mind that this is being recorded for on-demand access, and that if you have questions or comments, you can put them in the chat and the moderator will potentially call on you to speak. So I will hand it off to Dr. Pierce, who is going to get us started.
Thanks so much, Misty. It's always a pleasure to be here with you all on the Online Journal Club. I was really excited to see this paper, and congrats to Dr. Parmar and his colleagues on an excellent paper, and it's great to see you again, Gaurav. A high ABI, what does it really mean, right? This week, Monday, I got this consult, e-consult in my inbox, right? 71-year-old male, usual sort of things, diabetes, CKD, morbid obesity, unique skin condition we see here in Alabama. And they had a CT scan done to look for a renal stone. And of course, the radiologists can't help themselves anymore. There's severe calcific atherosclerotic disease extending throughout the entire aorta and bilateral iliac arteries, right? They want to know what to do. Right? This from an NP in the primary care clinic. So this is something that actually comes up a lot in our practices. And I think it's important that we have sort of a baseline understanding. I think we've all seen this probably in our patients over the years, especially those with diabetes or with chronic kidney disease, and certainly those with both. They get medial wall calcification in the arteries, Monkenberg's calcification, medial calcinosis. It goes by many names. It leads essentially to increased stiffness in the vessel wall, and these will be presenting as a high ABI. Hopefully, we all know that a low ABI is considered less than 0.9 and will diagnose a patient as having PAD, regardless of whether they're symptomatic or asymptomatic. But the high ABI is just sort of classified as abnormal. But I think we all know there probably is some adverse CV events and mortality associated with, but it's not really well understood in the literature. There have been a few studies that have addressed this. One was the Strong Heart study, which did correlate a high ABI with bad outcomes. But that was really specifically in a population of Native Americans. The Impact ABI study similarly showed some correlation between bad outcomes and a high ABI, but these were patients who already had existing CV disease, and they didn't look at all-cause mortality. So we're still sort of, what do you do with this patient who's not complaining of anything and theoretically doesn't have some diagnosis that gets sent to your clinic with a high ABI? Again, I think this is something we all have to know about, right? Because you think about what's happened just in the sort of the lifetime of one of your average medical students that you teach in your first year courses now, right? Just over basically 20 years, the penetrance of diabetes is absolutely incredible. And if you think about it like kind of an earthquake, those of us in the South certainly feel like we're in the epicenter of that with the kind of diabetic patients that we're taking care of these days. I think probably the thing that's the closest to what we're going to hear about tonight is actually a German prospective registry. And they looked at this issue when they looked at people in the general population. They said, what do we do about patients who have asymptomatic or symptomatic carotid disease? They actually excluded the high ABI patients, excuse me. But when they looked at patients who were symptomatic or asymptomatic, it showed that patients with asymptomatic PAD still have worse outcomes. So I think if we can correlate a high ABI, it's probably going to be somewhere in that range of patient, potentially a patient who really you could qualify as having probably asymptomatic PAD. And so I think that's what this study can show for us. And I'm going to turn it over actually to Angela Sickles, our incredible second-year resident who's in the lab right now. And she's going to go through the paper with us. And we look forward to a healthy discussion. Thank you all very much.
All right, good evening, everybody. Thank you for the opportunity to discuss this great article this evening. Thanks to Dr. Pierce for introducing our topic. We're going to be discussing high ankle brachial index participants experience similar long-term mortality as peripheral artery disease in a national sample of community-dwelling adults. So their data source for this project was the National Health Assessment and Nutrition Examination Survey, or NHANES. It was a CDAC initiative started in the 60s to gain information about major disease prevalence and risk factors, but became a rolling program in 1999. Has the country divided into 15 areas and selects 2 of them per year, randomly samples these areas, and tries to target a wide demographic. Participants are notified by mail. All medical exams and testing are free, so about a $5,000 value, and they're additionally compensated $125 for their time. And to the author's knowledge and mine, it provides the longest follow-up of 20 years for community-dwelling adults with documented ABIs. The research question for this study was, what is the mortality of adults with high ABIs compared to those with low and normal ABIs in the general community population? This flowchart demonstrates their cohort selection. They queried the NHANES database for participants surveyed between 1999 and 2004. Patients under 40 years old and those with ABI data unavailable were excluded, resulting in a total cohort of 7,693 patients. Of these, 8% had a low ABI, 89% had a normal ABI, and 3% had a high ABI using commonly accepted definitions we're all familiar with. Their primary outcomes were cardiovascular and all-cause mortality. Their mortality info was obtained from National Death Index linkage, and secondary outcomes included factors associated with low and high ABIs. So moving to their figures, looking at the risk factors for high ABI patients, these included diabetes, which had the highest odds ratio at 2.4, and coronary disease and CKD. They were less likely to be current smokers. CAD and diabetes were similarly found to be risk factors for low ABI patients. However, the association of diabetes with high ABI was stronger than the association of diabetes with a low ABI. Current smoking had the opposite effect here and was associated with low ABIs, and other risk factors included hypertension, lipid therapy, congestive heart failure, and cancer. Getting to their primary outcome, they demonstrated significantly lower survival at 20 years for both high and low ABI participants compared to normal ABI participants. This is for both cardiovascular specific and all-cause mortality. Here they demonstrate the Kaplan-Meier overall survival estimates as percentages at 1 year and then in 5-year increments. At 1 year, the survival difference is pretty minimal. However, the difference between the normal and the abnormal ABI groups becomes increasingly pronounced over time. And I've superimposed the trend lines here on the figure to demonstrate how this mirrors their Kaplan-Meier curves. On multivariable Cox regression, they demonstrated that a high ABI was associated independently with elevated cardiovascular and all-cause mortality after adjusting for demographic covariates. Hypertension, diabetes, peripheral vascular disease, cancer all also demonstrate independent associations, and it should be noted that there may be a correlation of these with high and low ABIs given their previous results in the logistic regression analysis. So moving into their discussion, they cite multiple other papers that have looked at high ABI patients and discussed their concordant and discordant findings. Starting with concordant findings, the Strong Heart study, which Dr. Pierce introduced in the introduction, was done in a Native American population and demonstrated higher all-cause mortality with high ABIs. However, a limitation was the generalizability due to a homogeneous population. The cardiovascular health study similarly showed higher all-cause mortality with high ABIs, though their normal ABI reference group was a little bit unusual, and even then the sample of patients with a high ABI was so small. The ERIC study was another community study looking at participants with high ABIs compared to normal ABIs, and the IMPACT ABI study was a little bit different because it was done in patients hospitalized for cardiovascular disease. Both of these studies showed no significant association of high ABIs with traditional atherosclerotic risk factors being smoking, hypertension, and hyperlipidemia. There was a large retrospective study out of the Mayo Clinic that looked at over 2,000 patients with high ABIs, showed that diabetes, CKD, CAD were all associated with high ABIs. Then they moved into the discordant findings, and this same study out of the Mayo Clinic also showed greater all-cause mortality versus low ABI patients. This finding has not been replicated in subsequent cohort studies or meta-analyses. It was done in mostly non-Hispanic white patients, which limits generalizability. And there was also a selection bias for symptomatic patients, as these were patients who presented to a vascular lab. They also found that there was a higher prevalence of diabetes and CKD in the high ABI patients versus normal and low ABI patients. The cardiovascular health study demonstrated no association between high ABIs and cardiovascular specific mortality. The MESA study showed no association between high ABIs and hard cardiovascular outcomes, which they defined as MI, resuscitated cardiac arrest, death due to coronary disease, stroke, or death due to stroke. And then the IMPACT ABI study also failed to demonstrate mortality association. It showed that high ABIs did not demonstrate any association with major adverse cardiovascular events in patients who were not on meta-analysis. And then the ERIC study also found no additional risk factors for worse outcomes for high ABI versus normal ABI patients. Some of the limitations the authors discuss are those inherent to observational and retrospective data, no detailed medication or intervention information for the patients who were queried, and then the small relative sample size of participants with high ABIs compared to the population surveyed. So the key takeaway that they describe in this paper is that high ABI patients experience similarly elevated long-term all-cause and cardiovascular mortality as low ABI patients, and both groups experience higher mortality than patients with normal ABIs. And therefore, they require the same attention to secondary cardiovascular risk mitigation as patients with low ABIs. They went back and forth on that last one a little bit in the discussion, but I think it's still a reasonable conclusion. High ABI is not necessarily a diagnosis, but rather represent a sign that's indicative of one or a combination of other comorbidities that require risk factor mitigation. So for our discussion of how this informs clinical practice, I think the big question is, how should we treat patients with high ABIs? And a good next step is additional vascular testing, TBIs, arterial duplex, and angiography. They cite another paper that demonstrated that 50% of patients who underwent angiography were found to have multi-level PAD of those who had high ABIs. I think we should also have a high index of suspicion for cardiovascular disease. High ABIs might be a surrogate for medial calcific disease, which has a higher incidence of left ventricular hypertrophy and arterial stenosis. And while risk mitigation approaches in this patient population specifically requires more research, it may be an indicator of other cardiovascular disease processes which have a strong evidence base for secondary cardiovascular risk factor mitigation. And then, of course, to treat patients appropriately if they're found to have vascular disease or require additional intervention after testing. Thanks very much.
Thank you. I think we'll start to open this up for some discussion. Don, did you want to start?
Yeah, no, go ahead. So that was a nice summary of this study. And I think, yeah, I mean, what do we do with the high ABI? And I guess a question maybe for initially the Dr. Sickles and partners down at the UAB, and then maybe for the authors. But what do we think is the driving force behind the mortality? Is this diabetes that we're just not treating because we don't see a difference early on, but then we see a difference, 10, 20 years. So I think this moves into where we are with our PAD patients now, and, rumors that Ozempic will have an indication for peripheral arterial disease. What are we actually going to treat to minimize this, or hopefully kind of level out those curves you showed us and decrease the mortality in these high ABI patients?
Angela, you want to tackle it?
Yeah, absolutely. I think that having a higher index of suspicion and then pursuing additional testing will probably categorize a lot of these patients into having diagnosed PAD that then requires intervention. And I think that if there's a population that you can kind of capture, even if high ABI is the only indicator initially when they present, I think that intervening at that time potentially have a mortality benefit instead of waiting until they present with some other sequelae of cardiovascular disease or diabetes.
I think the tough thing you're getting at, right, Don, is that there's already some end organ damage if their arteries are too stiff to manifest a normal ABI. So you're already dealing with a patient who's I classify them as probably the same risk as somebody who has asymptomatic PAD at the very best. Right, somebody whose ABI maybe is 0.8 and doesn't even, they do their business. So you don't give up on those patients, right? You can still affect their long-term mortality by not smoking, taking a statin, getting their hemoglobin A1C under control, managing their proteinuria if they have CKD. I think all those things are important. And I think probably the one thing too that wasn't mentioned in the presentation of the paper, but exercise. I think getting these people out and moving is probably going to be really critical to their long-term mortality. They may not even realize that they're at risk to have a heart attack or a stroke, much less some sort of limb complication, right? The additional vascular testing recommended is because that's what we think about because we're vascular surgeons. But I think if you're talking about mortality impact, you're talking about what are the other things we can do to decrease their risk of strokes and heart attacks.
Dr. Palmer, I'd love to hear your thoughts on this. I'd love listening to Dr. Pierce talk, but you did come up with this concept and write all of this up. So we want to hear your take on it, especially from a vascular medicine perspective.
He does have some interesting points in the chat box too.
Thank you. First of all, UAB is a home, so it's so good to see you all together. And I really miss you guys, I must say. So Dr. Bragg, Dr. Pierce, thank you. Thank you. High ABI, right now, there has been, as you can see, going back to the literature, and especially that paper that came out of Mayo Clinic, where they actually studied around like 3,000 plus patients from their vascular lab. So these are the patients who were presented to vascular lab for ABI testing. And that's the largest cohort known of high ABI. And they showed that their overall mortality was higher than, I think they have a 7-year or something like that, 6 or 7-year follow-up, higher than the PAD patient. And I think that startled me. And that paper was published in 2013. And there was no follow-up. I mean, we go to conferences and I ask this question, and like most of the lab reports don't report like they report normal or high ABI, consider calcification, but that's it. It's not classified as a disease process, and a lot of those patients don't get any treatment or any secondary prevention measures. So that was our idea. We already had a paper from the same cohort, NHANES, where we studied the social determinants of health and racial disparities in PAD patients, the same cohort. And but we did not include high ABI in that manuscript. And we wanted to see, it's only like 200 patients. So it was a very small sample to study the secondary risk prevention or some other stuff. But we wanted to see what the mortality is. And when we saw that the mortality is similar to PAD, that startled me and all of us. Like we started using reporting TBI in most of our all of our lab ABI studies, and kind of like try to look into what can we do to this population. I think for PAD, whatever stuff we know, there is a lot more that we don't know. Dr. Narula published in 2018 the autopsy data from amputated limbs, and then showing the thrombotic versus atherosclerotic pathology. And that tells you about different mechanisms maybe at play when you have infrapopliteal disease versus aortoiliac disease. And then people who get CLI may be totally different population than the traditional atherosclerotic PAD patients. I think the same applies to these high ABI participants. We did have a MGH cohort that we studied. We published, we presented an abstract at the Society for Vascular Medicine annual meeting, where we showed that the cohort basically shows that the statin therapy has been able to reduce mortality, but not the antiplatelet therapy. So I think that we are working on some other variables to look into what can be done or what evidence can we generate in order to help these high ABI patients. This is startling, right? Because these are all community cohort from NHINS, like from in-home visit, basically the ABI were taken. And so I feel like this is, like it kind of supports the Mayo Clinic paper because they were the sicker patients who went to vascular lab. And I think that high ABI, we should treat them at least with as rigor as the PAD patients. I think that we need to redefine PAD, but that's a different topic. And I think we are writing on that as well, because the definition of PAD on ABI is archaic. I mean, it's too old, and ABI is not a perfect test. We all know it. In vascular world, we try to read it between the lines, and we basically but not everybody else, right? In the primary care clinic, if the ABI is normal, that's it. That's the end of the deal. So, thank you for considering this paper, but I'm happy to answer any other questions if people have.
I'd actually like for you to talk a little bit more about the NHANES data set, which I know is not the focus, but you mentioned that this is a community cohort. And I don't know that I'm definitely not as familiar with it. And I don't know that we use it as much in vascular surgery. So maybe you can talk a little bit about all the things that you did, you have the ability to look at, or some things that you left out in this case and what it doesn't capture. Because again, you mentioned there are no dialysis patients in this.
So NHANES is a national health and nutritional assessment survey that has been going on for like 30 years now. There was funding to include ABIs or calculating ABIs only in 3 survey years from 1999 to 2003. And so that's the cohort that we have. There has been a lot of papers from this cohort from Dr. Pandey and Dr. Josh Backman from Brigham and Women's Hospital, and they have published exclusively on PAD. The advantage that we have now with the same cohort is we have a longer follow-up, because CDC released the 2019 all-cause mortality linked to the enhanced participants, and so that gives us a 1999 to 2019 like a 20-year follow-up, up to 20-year follow-up, and then we can look into the long-term mortality. So every survey year is a little bit different. They ask different questions. They have a classic nutritional questions and classic cardiovascular disease questions, but the vascular component is not very heavy. And I know the regards cohort has been refunded from UAB, and I know that there has been a interest in actually calculating ABIs, like in their next in-home visit if we recruit more participants in the regard study, and that would be something that would be useful. But NHANES otherwise has all the lab values, like there is an in-home visit where they collect lipid panels and A1Cs and CRP and all kinds of inflammatory markers and stuff. They have blood pressure records and blood pressure recording and stuff like that. So there is a lot more that NHANES provides, but it has limitations, and there has not been approval, like extra funding for after 2003 to add like an ABI measurement. It's a complex cluster sampling technique. They kind of sample around 5,000 participants across the US, which somehow is a representative of the US population. So somehow it, statistically you can actually compare year to year, even though the participants are different year to year. And then CDC kind of monitors with the mortality statistics. So then they link to the participants. So that gives us an advantage to kind of go back and look at the cause of death and follow up longitudinally.
Is there a way to link it to, say, Medicare or something along those lines so that you could, okay, that would be my big thought is, could you get even a little bit more data if there was a way to link it that way? But...
Right. I mean, there is no, to my knowledge, when we look into this, there is no cohort of peripheral artery disease or ABI from that far, right? I mean, there was no funding or interest to study this population. Obviously, cardiology was more focused on more, heart issues, so the legs were not priority. I think it's time to bring leg to the forefront of vascular care.
Then I could go on and on and on with questions. It looks like Neil Harani had a question. Just do you suggest that risk factor modification may be in order? but that we don't really have data or a protocol to support it. I
That's
think you
correct.
kind of answered that, yeah.
Yeah, that's correct. I mean, so we had a poster, we were looking into antiplatelets. So we're looking into basically 3 agents to kind of like the first is statin therapy, second is antiplatelet therapy, and third is ACE and ARB. And we basically looked at those in our MGH cohort. I mean, it was a small, obviously the data extraction takes time. So we just had like 100 plus participants, but even within those 100 plus participants, we saw that the statin use was statistically beneficial, but not the antiplatelet or ACE and ARB use. When you do the 3 combined together, all patients who were on all 3, they had a less proportion of risk of amputation and mortality. So I think that this, because nobody was studying even the mortality, I think that the identifying problem is the first step. The second step is to find the solution. But second step is to find the pathophysiology. Why these patients are dying? Like, is it heart attack? Is it the comorbidities? And then we can look into how can we mitigate those risks and how can we address one at a time. What do we need to do? So great question, but I think that more should come on this soon.
And then one other question just about the, your association in here was with diabetes. And there is a recommendation that patients with diabetes get a foot exam. But a lot of times that foot exam is done in a cursory way, and it doesn't necessarily mean that they're truly getting an assessment of their arterial flow. Do you think we need to make a recommendation for patients who have diabetes for a certain length of time, that actually the way to check their feet or do a thorough foot exam would be with ABI or toe pressure testing? What are your thoughts on that?
No, I mean, I totally, I agree. I think I see MGH here. I hope Dr. Dua is not here. She's a great friend, but she asked a very provoking question one time in our journal club. She said, like if these patients of like PAD patients, if they're, or CLI patients, if they're dying from MI, why don't we just like basically cath them across the board? Anybody with CLI should get a heart catheterization and then fix it. Very provoking question, right? We don't have the answer. I don't know, but at least we should do the foot exam. So, or the TBI or toe pressures checked out, I would say that a lot of times we run into the same issues, right? Like other than secondary risk prevention, what do we do? I would say that secondary risk mitigation strategies are very poor. I mean, surgically treated patient versus cardiology treated patients versus internal medicine or vascular medicine, like all of them, here and there, a little bit above and below. The statin prescription rates are like somewhere around 60-70%. The antiplatelet prescription rates are like 40%, 50% at the best. So I think we have a lot of things to do that, in that field to kind of like increase secondary prevention. Microvascular disease is another, and that's why I think Dr. Narula's paper on above knee versus below knee limbs was very, I think, very interesting to kind of look at the pathophysiology and see which area should we target first, because the microvascular disease of feet is a challenge. I mean, there are not very good treatment options so far. And like other than blood pressure and diabetes and cholesterol, we don't know, we don't have too many other resources.
Well, we'll throw one more question to you before we switch over that Dr. Frazier asked me. Asked if you suspect that these patients went on to develop diabetes?
Like the patients we have high ABI but don't have diabetes? That's a good question. I will have to go back and look into the cohort that we haven't looked. Good
All
question.
right. Well, and none of us never like to miss an opportunity to bring up the CARP trial. And Dr. Dahlman did mention that, cathing across the board was done in the CARP trial and didn't help. I love to bring up the CARP trial, So at this point, we're going to shift and we will ask Dr. Ferris to get us started on the next paper.
Okay, good evening, everyone. Can you hear me and see my slides?
Yes, all good.
Absolutely.
Yeah, on behalf of University of Vermont, really excited to be here tonight. Appreciate the invitation to participate in this journal club. Very excited to be talking about this paper. To be honest with you, textbook outcomes in vascular surgery is, I had no idea about this new novel kind of composite metric that is being discussed. And I think it's exciting because I believe in the coming years, this is going to continue to gain momentum. And I applaud the author, specifically Dr. Felstead, who's joining us tonight on her work. So in the next few slides, I'd just like to try to provide a little bit of a background over maybe the last 20 years in terms of how we got here, in terms of outcomes in vascular surgery and quality and the assessment of both. Traditionally, individual outcome parameters have been used to assess quality of care. And so this is your mortality, length of stay, complication rates, readmissions. There's been a well-established relationship between hospital volumes and mortality in elective high-risk surgeries. In early 2000s, there were efforts to reduce surgical mortality by trying to concentrate these specific high-risk procedures in high-volume hospitals. An example of this is the Leapfrog group. The counter argument is that volume is an imperfect proxy for quality. There's certainly low volume centers out there that are doing excellent work and have excellent outcomes. Conversely, there are high volume centers out there that have poor outcomes. A lot of work has been done looking at volume and outcomes and related to certain surgical procedures. An example of this is from Dr. Berkmeyer and his co-authors that was published in New England Journal of Medicine in 2002. And it was a retrospective study using Medicare claims data in the nationwide inpatient sample. And they looked at the volume mortality relationship among 6 cardiovascular procedures and 8 major cancer procedures between 1994 and 1999. Overall, they analyzed 2.5 million procedures. And not surprisingly, they found decreased mortality across all 14 procedures with increased center volume, similar to a lot of other publications that have been done over the last several decades. And the magnitude of difference varied between the procedures. So for instance, pancreatic surgery, ended up, the higher volume centers had the greatest difference in mortality rates. Whereas, for instance, carotid endarterectomy had the smaller magnitude of difference. But for specifically open AAA repair, the higher volume centers, if they divide them into quintiles, and these were centers that were performing more than 79 open AAA repairs per year, their mortality rate was much less than the lower volume centers, 3.9% versus 6.5%. Similar study was from Dr. Dimick and his co-authors. It was published in JVS in 2003. And this looked not only at hospital volume, but also provider variables. So surgeon volume and surgeon specialty, specifically looking at repair of intact AAAs. And it was, again, a retrospective study using the nationwide inpatient sample data from 1997, over 3,900 patients. And high volume centers were classified if they repaired more than 35 AAAs annually. High volume surgeons were greater than 10 open repairs annually. And they looked at the specialties of general versus cardiac and vascular surgery, the primary outcome being in hospital mortality. Again, not surprising, similar to other studies, they found that the higher volume centers performed better in terms of decreased mortality rates, as well as the higher volume surgeons. And this was an additive effect. Additionally, the surgeon specialty with vascular surgery having the lowest rates of in-hospital mortality. And so they suggested not only should hospital volume be looked at in terms of referrals for patients undergoing open AAA repair, but provider variables, specifically the volume of repairs they're doing in their specialty. The big bugaboo came in 1999 when EVAR was FDA approved. And this resulted, as you know, in a paradigm shift in the treatment of AAA. And so there was a rapid decline of open surgical repair of AAA in the subsequent decades. And this resulted in decreased hospital volumes as well as increased case complexity. Dr. Conroy's paper that was presented last year, he illustrated this well, and this, I believe, is published in JVS this year, of the rates of intact AAA repairs from 2004 to 2019. And as you can see from the illustration or figure on the left, the rates of open surgical repair went way down with the rates of endovascular repair and complex EVARs going up over time. And so for intact AAAs, open surgical repair was 55% in 2004 of all interventions performed for AAAs versus 11% in 2019. Similarly, they found a trend in increased mortality of open surgical repair over this time period from 4.4% to 5.1%. In 2018, SVS published practice guidelines related to open surgical repair of AAAs with a recommendation that it should be performed at centers with a volume of at least 10 open aortic operations and a documented perioperative mortality of 5% or less. In the last 10 years, this concept of a textbook outcome has come about, and it's was introduced in vascular surgery back in 2017 by a Dutch group. It really didn't gain much traction then. Fortunately, Dr. Felsted and her co-authors have reintroduced it recently, and I believe we're going to see a change in the coming years. And so this is a composite metric as opposed to the individual parameters that we commonly look at that can be used to measure the success of a quality of a surgical procedure. So it's the ideal or optimal outcome that's typically patient-centered. And it allows us the ability not only to assess patient-level outcomes, but hospital performance that could result in center designation as well as quality metrics. There's been a lot of this published and used in other surgical subspecialties like HPB, colorectal, and transplant surgery. And I believe we'll see more and more of this going forwards. I'm going to hand it over to my senior fellow, Dr. Sean Leifsher, who's going to present the article.
All right. Thank you, Dr. Ferris. Thank you, everyone, for having us tonight. Like Dr. Ferris said, my name is Sean Leifsher. I'm the Senior Vascular Fellow here at the University of Vermont. Happy to talk to you tonight about the paper by Dr. Felsted and her colleagues entitled A Patient-Centered Textbook Outcome Measure Effectively Discriminates Contemporary Elective Open Abdominal Aortic Repair Quality. So the authors of this study sought to address the question of how to define the quality of a surgical outcome in ways that are more meaningful both to patients and to physicians. As Dr. Ferris noted, traditionally, quality has been defined in terms of quantity, with hospitals and healthcare systems often relying more on outcome metrics like mortality and surgical volume to serve as a surrogate for quality care. More and more, though, I think we're coming to realize that what patients consider meaningful after a procedure and traditional outcome metrics don't always align. And so to address this discrepancy, the authors are proposing a new metric or a textbook outcome that contains more nuance and is therefore more meaningful to both patients and physicians. The goals of this study were to develop a patient-centered textbook outcome measure for elective open AAA repair, determine the feasibility of this textbook outcome to discriminate between hospital performance, and determine what factors affected the occurrence of a textbook outcome. So an ideal textbook outcome, they noted, should allow for a comprehensive accounting of the perioperative course that is meaningful both to patients and physicians, is specific to the disease being studied, related to the surgery being performed, and will help facilitate comparison between those two groups. And so for the characteristics of the study, this was a retrospective cohort analysis of the SVS VQI open infrarenal AAA repair database, looking at all open aortic repairs from 2009 to 2022, non-elective repairs and repairs where the center volume was unable to be calculated, as well as patients with missing information on the textbook outcomes were excluded, leaving 198 total centers with just over 9,500 total repairs. The primary endpoint for the study was a textbook outcome, which the authors defined as no in-hospital complications, no re-intervention or reoperation, and discharged home in less than 10 days and alive for more than 1 year post-operatively. Secondary outcomes that looked at included adherence to the SVS open aortic repair clinical practice guidelines, as well as traditionally reported outcomes like those seen here on the slide. The authors note they chose these outcomes based on literature-based precedent in non-vascular surgical specialties, a review of a recent consensus document providing recommendations surrounding quality assessment after surgical interventions, and the importance of these outcomes to patients as described in recent reviews on the topic. The patients were divided into two groups, those that experienced a textbook outcome and those that did not. A univariate analysis was performed to compare patient and procedure characteristics, adherence to the SVS clinical practice guidelines, as well as annual hospital volume. And a logistic regression was performed on 40 candidate predictors to create a predictive model for a textbook outcome. What they found was that a textbook outcome, according to their definition, occurred only in 44% of cases, that it was more likely to occur at those centers that performed 10 or more open aortic repairs per year, at 46% of the time, compared to 42% of the time for centers that performed fewer than 10 open aortic repairs per year. The figure on the right compares the individual components of a textbook outcome between high and low volume centers, and you'll note small but significant differences for each of the components. Similar findings were seen in adherence to the SVS clinical practice guidelines. Overall adherence to the guidelines was low at just 10.1%, with 11% of high volume centers following guideline versus 8% of the low volume centers. The authors then looked at the feasibility of using textbook outcomes to discriminate between hospital performance. They looked at the observed versus expected rates of textbook outcomes after adjusting for relevant patient and procedure-related factors shown on the figure at left. And the figure right shows the textbook outcomes have a much more normal distribution across the different centers compared to outcomes such as in-hospital mortality, suggesting that a textbook outcome has the potential to help evaluate hospital performance and quality. Finally, they looked at what factors could independently influence the likelihood of a textbook outcome. They noted that adherence to the SVS clinical practice guidelines regarding perioperative antibiotics and performing more than 10 open aortic cases per year were really the only two independent factors that made a textbook outcome more likely, as well as a list of different outcome factors that made a textbook outcome less likely, the biggest of which they noted being age decreasing 5% per year, as well as perioperative creatinine of 1.8 or more on or those patients on dialysis. They did note a few limitations for the study. First, certain patient-centered outcomes are not included, such as quality of life and readmission. Second, this was a registry study, so it was impossible to adjust for all the different co-founders, as well as variations in postoperative care and regional discrepancies in resources. And additionally, textbook outcome treats all postoperative complications as equal and doesn't account for the differing severities that could be encountered. And so finally, in conclusion, the authors note that the textbook outcome offers a more nuanced, comprehensive, and patient-centered method to ensure to compare care delivery than traditional outcome indicators.
All right, well, thanks. That's a great sort of summary of some pretty complex data. And I think a couple questions maybe we'll address Dr. Felstead. So the one thing that stands out in that is this whole thing with the antibiotic guidelines. Obviously, you guys think as authors that that was a marker of perhaps centers that had more protocols that they were following, not just in terms of obviously the antibiotics, but everything in terms of postoperative care with an open aneurysm, where they had sort of pathways to care in terms of feeding, rescue, all these things that probably play into this textbook outcome. Maybe you just want to give us a comment on that, Dr. Felstead.
Yeah, I absolutely think that is kind of the idea. It's also specifically not just did the patient get antibiotics, because I think most of us are good at making sure that there's antibiotics. We have surgical timeouts that generally address that. But did they get the antibiotics that met the guideline for the procedure? Did they get them in the right time? So there's some really specific things about meeting those guidelines. And I think that is a marker for centers that do have more rigorous protocols, who have more experience, both as surgeons, but as operative teams, and probably have more of those safety nets in place, so that there's less failure to rescue for patients, a number of things that kind of all summative improve the overall outcomes for individuals and for their cohort of patients.
Yeah. So I think a good question here from Dr. Bai. Overall, looking at these numbers, and I guess it was significant, but overall we're 44%. So, great numbers for baseball, but not amazing in surgery, that were batting less than 500. And even then, the difference between the low volume and high volume. So 46 versus 42, significant in what you guys presented here, but not that great either way. So Dr. Bai's question here was, so, what can we do to help achieve the textbook outcome? Obviously kind of the pinnacle question, but maybe you can comment on that for us.
Yeah, absolutely. I think that that was certainly one of the things that was most outstanding to us when we started crunching these numbers was like 44%. That's pretty terrible if we, look at ourselves and think that, hey, we're good surgeons, we're doing the right things for the patients. I think it was eye-opening to kind of reevaluate as a whole and as individuals. I was in fellowship as I was writing this, like when we're looking at a patient in clinic and we're offering them a surgery, we say, hey, this is a young patient. We think that they're a good candidate for an open aortic repair. And we lay out for them, what does that look like? Then to think, well, we only actually achieve this in less than half of the time. So maybe we need to be counseling these patients differently. I think it's also important that we're measuring these things. If this is what we want for our patients, and we don't realize that we're not achieving it, it's hard to make changes in our protocols to help our patients get to those outcomes. I think that your point was very salient about the difference between the high outcome or high volume and the low volume centers being really small, 4% difference is not a whole lot. And I think that that speaks specifically to that question of, is volume a great marker? If the high volume centers aren't doing that much better, why? Is that because the high volume centers are taking in sicker patients? They're calling these elective, but maybe they're not quite as elective as the patients who are getting them at low volume centers. Does it mean that the low volume centers are doing a pretty good job compared to high volume centers in picking patients that are appropriate to have their procedure done there? And maybe they're turning down patients who wouldn't do as well and sending them to high volume centers. I think there's a lot that we can't unpackage there from a retrospective study, but it's all things that we want to look at as we kind of are establishing the textbook outcome and trying to more prospectively look at how we can improve our outcomes, how we can improve them on a national level as well as on an individual site level. And then, how we are working with our patients. One of the things that came out as specific for not achieving a textbook outcome was that creatinine of 1.8, so CKD of 3 or CKD 3. And that wasn't something that I necessarily specifically expected that, like maybe I thought, well, dialysis, we know that there's a specific relationship between dialysis and poor outcomes in many of our vascular procedures. So I expected, CKD 5, but I wasn't necessarily expecting CKD 3 to be the tipping point for outcomes for these patients. And so maybe when I have patients who are coming into clinic with CKD, which is common, I need to think a little bit differently about how I am talking to them, how I am presenting options to them, and making sure that my assessment of their risk is appropriate. So I think there's a lot to be unpackaged there in terms of how we're assessing risk for our patients and how we're selecting our patients. And then one of the things I think Sean briefly showed the figure where you look at the individual centers, and if you look at it closely, it's a little bit of a there's a lot of data in that figure. But if you look at it, basically, no matter where you are in the scale of volume, there were hospitals that were clearly exceeding the expectation and hospitals that were clearly not meeting expectations. And so I think that there's a lot to be done on an institutional level to look at, are we meeting our expectations? Are we meeting the national expectations? Where do we stack up? It's great if we're doing 100 cases, but if our outcomes are poor, perhaps we're not, we're not performing in the way that we need to. And maybe we need to look at our systems that we have in place to determine what we could be doing better and how we can get there.
Yeah, I would like to add one other thing, if that's okay.
Yeah.
Of these rates of achieving the textbook outcome, of the 40, 42, 46%. It seems low to us, right? Again, it's a complex procedure. But if you look at the other surgical specialties that have been using this, and I kind of looked at the same papers that you cited in your article, it's similar rates, from pancreatectomy to, big, colorectal surgeries, cancer operations, their textbook outcome is less than 50% often, depending on their composite metric. What I struggle with, I think it's good, like for us as physicians, surgeons, for hospitals to look at that, for societies to look at it for accreditation, and potentially payers for reimbursement. But to talk to a patient about that, is I think it's challenging. And in the age of patient-centered care and patient-reported outcomes, it's much easier, I think, for a patient to understand, hey, you have a 2% mortality risk with this procedure. I think they would understand that much better than, hey, there's a 40% chance we'll get this great outcome. So I'm interested to see if anyone else has any ideas, as we approach this patient-centered, model going forwards about, how to include them in the conversation when they're going into, complex cases like this.
I am very interested to hear what other people think. I will tell you that my thought around that was not necessarily so much that when I'm talking to a patient, I'm going to tell them we have, this rate of textbook outcome at our center, but it was more looking at those numbers as an institution saying, where do we stack up next to other centers of similar volume or other centers in our area? And where are we falling short within that? Is that because we're having more interventions? Are they having more in-hospital complications? And what are those complications? Can we be targeting these issues, with some sort of systemic approach to the problem to improve our outcomes? And we haven't gotten to the point where we have some of the granular data that I would like to have, but which patients of our subpopulation are not meeting the textbook outcome? If it's really all, patients that have bad COPD, do we need to be working with our pulmonologists and trying to, in our ICU teams, to try and optimize something that we're missing there to improve their outcomes? But I think there's a lot of ways that you could look at this data to try and improve things for patients.
We wanted to hear from Dr. Pierce earlier, but now it looks like Dr. Beck has his hand up. Oh, here we go.
Yeah. Well, I just wanted to say, first of all, I thought that was a really great presentation. This is essentially supposed to demonstrate what is a perfect outcome from a open aneurysm repair. And I think if anybody told you that they had truly a perfect outcome from more than about 40 or 50% of their open aneurysm repairs, I think everybody would look at them sideways and know that they were lying. It doesn't mean that the patients did poorly. It doesn't mean that, you're killing a lot of patients. It just gives us a really good benchmark for looking at these questions that are great questions that are in the chat about, which centers are really having the most perfect outcomes, and how can we compare ourselves to them, and what are we doing differently, and what can we do better?
Yeah, I think just to follow up on Dr. Beck's comment, there's a nice comment from Dr. Bai. Maybe it's worth looking at you have a bell curve here now. That's what you sort of showed us, rather than one of these very skewed ones looking at mortality alone. So looking at the bell curve and taking the top, whatever it is, 25%, the top quartile, can we learn from what these centers are doing, whether they're high volume or low volume? Do they have set protocols? Are they selecting patients? Do they have a big FEVAR program that's, selecting out the more complex, slightly more complex open cases? So I think, I don't know if you have that data, or the VQI can provide that through what you've done already, but maybe highlighting what this top quartile is doing perhaps differently than the rest of us. Or maybe we're part of that. I don't mean to say that.
No, I don't think we have all of that data yet. It's definitely along the lines of things that we've talked about in terms of additional avenues that we can continue this work. But I think that's exactly right, is like, how can we find the teams that are doing this really well, and what can we learn from them? How can we improve our own performance for patients?
Right. Dr. Brill, you think there are any more questions in the chat we haven't addressed?
There was just one comment here from Dr. Fazer asking about, does the fact that DQI excludes all open aneurysms that are suprarenal impact the implications of these results?
I think it does. We chose a cohort very specifically to try and have as standardized a patient population as possible, making sure that they're all elective, all infrarenal, because there is a lot of variability in terms of experience and risk and intraoperative complexity that just broadens as you get into the suprarenal clamping and you get supraceliac and who's doing that and whether or not we're doing those as fenestrated repairs. I think we wanted to eliminate kind of some of those variables as we were trying to do this introductory work, but certainly those are areas to look into. And we also recognize that these hospitals that we have are hospitals that are voluntarily reporting this data. So there's a whole host of hospitals that we don't have any data for that may be performing very well or performing very poorly, but they're not participating in the registry. And so from a real world perspective, we probably only have hospitals that are trying their hardest to adhere to the guidelines and they're willing to put their outcomes out there voluntarily.
Thank you. Thank you very much for such a great discussion, and to Dr. Felstead and Dr. Palmer for being here to be able to answer questions. It is truly some of the best discussion that we have when the authors are here to give us insight into the work and to help us understand what questions we're all grappling with. I also want to thank Dr. Burrill for being here and being our moderator. And then, of course, Dr. Ferris, Dr. Lebsher, Dr. Pierce, and of course, Dr. Sickles for being here and going over everything. Great presentations. We will see you again in November, November 9th, I think it's the second Wednesday in November. And we will see you then for the November JVS Online Journal Club. Thank you and have a good evening.
Right.